wait me to go to his party. And I'm saying that just to mention that being here means that I really believe in what you do. And I thought that it would be an important signal from our state and from our government, my presence here, to reassure that we understand the importance of what you do and that we are here to use state's infrastructures and state's power in order to make it even better. And you know that our whole philosophy as a government during these 3 years of my new term is collecting data everywhere. I don't know, Professor Elliott, if you know that, but Greece in the recent 3 years managed to establish a digital health record for each Greek that all of us have in their phone, that have scanned all our population for various diseases. One of them is cardiovascular. We have scanned 5.9 million people, practically the 100% of the people that we should scan, because we're 11 million people overall, but elderly and younger people goes out of the question. So practically we have managed more than 90% of the people now have been scanned, and in real time their data comes in the medical digital health record, and we have data for almost everything. But what we really want to do in order to close up this effort is to make a genomic scan for our population. This will be the next round of our effort. And you know that we recently announced that we secured from the Prime Minister an extra budget of 75 million per year for diagnostics only, so we could use some of this funding even for your network to see how we make it even more professional. Now we have the money, we have the vision, we have a scientist, we have a network, and we're trying to establish the confidence of the people to this new world that is coming, to avoid all conspiracy theories about genomics and whatever comes to our strange era, but use this information to the benefit of our patient. And of course, in the rare diseases, genomics could be the new era. Practically, as science goes fast forward, and it will, all this new technology we have now will help us to improve ourselves in a much faster way than we did before. And we have a vision as a country. This time, Greece will not be at the end, but will be at the forefront of evolution. This is the real decision we have made for this country. This is the reason we work so hard. And we think that with your help, we will achieve our goal. And I want to say publicly that my cooperation with the Association of the Cardiologists is very important for the Ministry of Health. I think it's a unique example of good cooperation. We designed together the Prolambano program for cardiovascular diseases. We have proved that we not consider ourselves as wisdom people that knows everything. On the contrary, we want to hear the specialists that know their job and give us the right advices, even to correct decisions if they are not as they should. This can happen in life. Smart people can find a way out to do the right thing when it has to be done. And with this good faith between us, I think we will continue. And at the end, people will understand what we're doing already now. Public opinion has started shifting a lot as if for public health policies. And I think the future will be bright for Greece and for Greek patients. We want to be a significant part of European evolution of the years to come. And Professor Elliott, you have to know that you have an advantage. In this new era of AI, Greece is a small country, but not too small, but not too big. We have a centralized system that the Ministry of Health can design, decide, and apply. which is not always the case in all the other European countries. And this can save us time in order to take decisions and implement policies. And we will do with you as more as we can. We are very proud about our scientists. We are very proud about our medical community. And we trust them that they will lead the way, and we will just offer them the ways to do their job as best as they can. So thank you very much for being here. You are very welcome.
May I ask Professor Kyriazis to give us a short, address a short lecture?
Yes, of course. Good evening for everybody. Thank you very much for this invitation. Dear Professor Vardas, dear Professor Anastasakis, dear Professor Elliot, distinguished ladies and gentlemen, thank you very much for this invitation again. The National Network for the Prevention of Sudden Cardiac Death in the Young and Precision Medicine in Cardiology was established in July 2019, coordinated by the Unit for Inherited and Rare Cardiovascular Diseases at the Onassis Cardiac Surgery Center. It represents our response to that challenge, and it has been a substantive one. This is a landmark initiative financed through the National Public Investment Program. I use the word landmark deliberately. This was not merely a research program, but it was a deliberate national strategic choice. This program began when Deputy Minister of Research was Professor Fotakis, and I continued this when, from July 2019, I took over as Secretary General for Research and Technology, with Adonis Georgiadis as Minister of Development. And then, in September 2019, Professors Vardas and Anastasakis came to my office and sent out the project design. I will not conceal that I was impressed. As I subsequently, following its progress, I came to appreciate the rigor of the work being undertaken and the significance of its findings for the medical community, for young people, and for society at large. It was for the reason that I strongly supported the launch of a second phase of the initiative, bringing together 13 partner institutions, and the first phase, I believe that it was 18 institutes, securing the necessary funding. The path was neither easy nor without its difficulties. There were obstacles. They were overcome through persistence and collective effort. Today, the network has completed its work across two phases, with a total investment of approximately 6 million euros from national resources. The objective has remained constant, precise, systematic, equitable, but the tools now at our disposal are incomparably more powerful. At this point, I wish to build on a question that arose repeatedly during the course of this project, and which I believe runs as a common trend through the sessions of the conference. Who stands to benefit from the genomic revolution? Genetics and artificial intelligence hold the potential to transform medicine, but only if the health systems, the policies, and the institutional frameworks surrounding them guarantee equitable access to all. That is our obligation, that is the mission which brings us together here today. Thank you very much.
Thank you very much for the introductory speech, and I would like to ask Fotakis to make also a presentation regarding the whole network. Thank you very much.
Thank you, Mr. Chairman. It's a great pleasure to be here tonight, since, of course, I see Thanasis in the audience. Also, several other friends and colleagues from the past. It's like a reunion. So, thank you for inviting me and giving me the opportunity to address this conference, which effectively is a testament on the work we have been doing. We have started about 10 years ago in the Ministry for Research and Innovation, where I used to serve as a minister. That time was a very difficult time, and the flagship initiatives, as we call them, the action on cardiology, precision medicine in cardiology was one of these flagship initiatives. Flagship initiatives was part of our research policy. A research policy in times that the country was very close to bankruptcy and severe austerity measures were in operation. I'd like to give you some facts just to give you a feeling of what was going on. First of all, between 2010 and 2015, the national GDP had been decreased by 25%, and salaries and pensions followed a similar trend. Now, particularly in health, the decrease of expenditure, public expenditure, was 40%. It's very serious. The morale in society was very low, and the situation in academia and research very stagnant, without any jobs and prospects, especially for the young scientists. So this was the situation which effectively leading many young researchers, young scientists, medical doctors to leave for abroad. And just to give you a last sort of argument, the brain drain between 2005 and 2015 had been increased by 10 times. So that was the situation we had to face. So despite this gloomy situation, despite these severe austerity measures, the government then gave a lot of emphasis in supporting research, and there was a very substantial, for the time, increase in research, in public research expenditure. So, point was what we were doing with that. First thing we had to do was to take measures for capacity building, effectively to support the people of research and academia, especially younger scientists. This was the first priority for us. The second, among other measures, was to initiate some top-down activities which effectively gave the opportunity for demonstrating the impact research may have to society. So these activities, we call them flagship initiatives, and the flagship initiatives in precision medicine was one of these, the most important, I should say. So there were three actions along these lines. First of all was the action on the precision medicine in oncology. Second, precision medicine in neurodegenerative diseases, and the third, precision medicine in cardiology. In this last case, as very well known, the emphasis was on cardiac hereditary diseases, especially diseases which may lead to sudden death. So we were very lucky at the time that Panos Vardas, a friend from the old days, and Aris Anastasakis came and we had a discussion and effectively worked out the project on precision medicine in cardiology. Now, the idea behind that was, first of all, to create a situation that the outcome of this work would be close to people. I saw earlier a notice is how you can bring this to the community, how you can bring all this knowledge to the community. So all this work, the idea was to come close to the people and to be accessible by everybody through the public health system. That was one of the emphases. There were other aspects as well. By combining recent advances at the time in next generation sequencing techniques, to try to collect data, good quality data, that's very important, as I'm going to say, and to combine them with clinical studies for forming a data bank which can be used so that precision medicine could use personalized medicine. So this was the idea, and I'm very glad that following my term in the ministry, Professor Thanasis had the inspiration to continue the work which started then. So that's what we did, and I'm very glad to see the fruits nowadays. Before I close, I would like to make some comments because we are going to hear later, I think there are some talks on the artificial intelligence and the new technologies. So I do think that new technologies open up several prospects, several possibilities, but of course, as everybody knows, we have to be careful. And I would like to make two comments. The first comment has to do with the following. AI, artificial intelligence, we all like to use this word nowadays, relies on good quality data. And good quality data may be obtained through the public funding system. There is more into that, but this is very important. The second point, and perhaps I think more important, is that, as you realize, I'm far from any technophobic approaches, is that we have to be very careful in the sense that without any social and political control, the prospects opening by the new technologies, the paradise new technologies promise, may be easily transformed into hell. So I would like to stop here and thank, first of all, Professor Vardas, who has been chairing this initiative, Dr. Anastasakis, who is the coordinator, and all of you here who are participants in this effort. Also, I'd like to say that your presence here tonight, this evening, is a clear manifestation for me, especially the guests who have come from abroad, and distinguished guests who have come from abroad, is a clear manifestation that the effort we started then, 10 years ago, has bear fruits. Thank
you. You were the soul of this procedure.
Thank you very much. Indeed, I have not prepared anything to present because I presented 2 words yesterday more officially, but just I cannot avoid this temptation to say very few things. First, we had the opportunity just now from the ex-Minister of Research to understand how we started this new project from scratch. This is one. In my capacity as chairman of the oversight committee of this network for precise medicine and cardiology, I feel as a first priority then not to speak more about the history of this project. Everything is clear. Everything is clear about the results. Even it's clear how much important it is to focus on the perspectives. So we have to be essential to avoid flatteries. Just, however, I would like once more from this position here to thank from my heart first Kostas Fotakis, the ex-Minister of Research. You have understood that his contribution, his decisions were pivotal, fundamental, because nothing was there. Zero. Second, I have to thank from my heart the ex-General Secretary of Research and Innovation, Mr. Kyriazis, who belongs and serves another political party. And this is magnificent. But this project enjoys the support of different political parties in tandem, which is the secret of its success. So, thank you very much, Mr. Kyriazis, also for this and your understanding. Then, I'd like to thank from my heart Onassis Hospital, Onassis Cardiac Center, and its president, Professor Boletis, because this very advanced institute accommodates and supports this project. No doubt, no doubt. Thanks have to go first to Dr. Anastasakis, who was from day one beside me to organize the whole concept, and he is the chairman of the scientific committee. You see, there are two levels, the oversight committee and the scientific committee. Thanks goes to Professor Elliott, who is working with us, as you know. He's a very distinguished professor in Europe, and I don't know if UK is Europe, but anyway, in Europe. So, and of course, I would like to thank the whole network, these protagonists, 18 centers, one by one, a number of those involving a number of persons. So we are very proud as an oversight committee that we are so much well collaborating with these marvelous persons. And one of the main advisors in our efforts is Professor Thanos, who is humbly enough sitting over there, because with his advanced and mature expertise in genetics is a particularly important role in this project. I see a lot of very nice persons like Professor Vlachopoulos, Professor Naka. I see very important protagonists indeed of this effort. My heart, I'd like to thank all of you. Thank you very much.
So, I hope you can hear me. Hello, everyone. So first of all, I would like to say that I'm very happy that Professor Fotakis is here. He's my previous boss from Fourth. So, thank you very much for the introduction as well. There is an issue for asking. So, my name is Irini Koudoulaki. I'm a research scientist at the Institute of Computer Science, Fourth, a senior one. My research is about data management, and more specifically, for the last approximately 9 years, I'm working on health data management. So I would like also to thank Dr. Anastasakis, who actually included me in the program of this conference. also suggested that I talk about the collaboration between AI and humans. He also provided me with the title of the talk, When AI and Humans Work Together, the Story Begins, which is the motto of the students of the medical school of the University of Padova. Now, when he told me the title, the first phrase that came to mind was this one: "Nobody's perfect," from Gene Wilder's 1959 movie, Some Like It Hot. So in this talk, I'm going to try and make a case of why it is absolutely necessary for humans, and from all sides, all spectrums, and AI creators to collaborate with each other in order to produce useful and not harmful AI models. So let's start with how the health data lifecycle and AI interact with each other. So first of all, we have the patient who goes to the medical doctor. The medical doctor collects the patient's data. Then the medical doctor also orders more tests, collects more data, provides a diagnosis for the patient. Then the AI model is trained on patient data. And in a future term, the MD uses the AI model to treat other patients. So in this infinite cycle, the data is collected by humans, and the data comes with mistakes, with inconsistencies, and maybe with the data might be incomplete. So since nobody's perfect. Then the AI models are again created by humans, and the models might include biases and errors, so AI models are not perfect. And at the end, AI models are trained with data that humans produce, so imperfection is all over the place. So if the data is not clean, as Dr. Fotakis said, Professor Fotakis said, we will have garbage in and we will have garbage out. So the purpose is to have gold in and gold out. Good quality data so that the algorithms that we produce have certain characteristics that make them useful for the patient. Before I continue, I'm going to give you some facts, at least for me. So first of all, the patient must be the center of attention. The patient is the focus. It's not the insurance companies, it's not the doctor, it is the patient, right? MDs should use, and this is my point of view, should use AI as a support tool, not as their replacement. So what Professor Elliott said, it's me with my patient in front of a screen, I type something and then AI, ChatGPT says something, and then I report it to the patient. This is not the way to go, okay? So what we know is that AI handles data and patterns and probabilities, but MDs bring character, empathy, context, and intuition. Those are characteristics that AI algorithms, up until now, and I hope that will never have. Okay? So, the bottom line is that AI may be able to efficiently process huge amounts of data, big data, even bigger data, but the MD, the medical doctor, the clinical experts actually understand the patient. So, in order to be, those are the facts. Now, I'm going to talk about the properties that AI models should have in order to be, again, useful and not harmful to the patients. So, an AI model for healthcare, and I'm focusing on healthcare, should be explainable, should not be biased, should be lawful, should obey the law, the legislation, should support patient transparency, and should be validated. Okay? So these are the 5 pillars, at least the 5 properties that, in my opinion, AI models should have. Ethics and trustworthiness transcend those 5 pillars. You find ethics everywhere. Okay? So I'm going to discuss each of one of those pillars in detail in the following. So let's go towards explainability. So explainability sums up in the question, why did the model arrive in this conclusion, okay, in this decision? So for many AI models, to provide an explanation as to why they reached a certain conclusion is very hard, especially for deep neural networks and for large language models as LLMs. So without an explanation, at least as far as I'm concerned, a clinician has 3 choices. The first one is to say, okay, you said X, I go with X. The second one is to say, you say X, but I guess, maybe you said X because of some reasons that I don't know about. Or the third one is to completely reject the suggestion of the model. So what are the ethical risks there, to my point of view? The ethical risks are actually two sides of the same coin. It's about trust. If the medical doctor is blindly trusts the AI model, then there might be diagnostic errors. As we said, nobody's perfect, right? Depends on the model. And the second one is blind distrust. If the medical doctor does not trust the model, then the model might miss on accurate, might lose some accurate, interesting, and useful suggestions of the model. So how does the human in the loop come? So the MD should be able to comprehend the data and the reasoning behind the conclusion in order to be able to trust, to verify, to validate, and to learn from the model. Okay, so there should always be a feedback between the person, the human, and the AI. Always a feedback. Now, unbiased. An AI model should not be biased. So AI models that are trained on biased datasets, only Caucasian males over 60, and close my parentheses, they are based on flawed assumptions that by default fat people will have a heart attack, for instance, or embed human beliefs, okay, or prejudices, have worse performance. So for instance, an AI model that is trained from, with data from white Anglo-Saxon Protestants from the Upper East Side of Manhattan should not be used to predict the risk of heart failure for African Americans that live in Chicago, right? Because we are talking about rich white populations versus black poor populations. So where is the ethical risk here? The ethical risk is that biased AI models could silence certain patient stories, turning healthcare into one-size-fits-none approach. So we develop models that are not good for anybody. Okay? So where the human in the loop comes, the humans should be the bias auditors. They should see the algorithm, they should see the outcomes of the algorithms, and see the performance difference. If I take one algorithm, the performance difference in the sense that how does an algorithm work in an environment X, and how does it work in an environment Y, in a context Y. Lawfulness. We discussed about lawfulness in the previous talks. More or less, is which laws are violated, because it's very hard to find out which laws are actually we are in accordance with laws. So the European Union started in 2016 with GDPR, the General Data Protection Regulation, that actually manages and handles, deals with the protection of personal data, but it also includes health data. And until the last law, which is the European Health Data Space, that regulates the secondary use of data. And it was up and running in 2025, not yet in full effect. In addition to the European laws, we also have national health laws. And we also have ethical governance frameworks that come from, for instance, international organizations such as the World Health Organization. Now, as I said before, the patient should be the focus of attention. So AI models, we know that AI models learn from patient data, but patients often don't know how their data are used. So the questions that must be answered by the developers, by the designers of an AI model are the following. Are the data that those models are trained with legally obtained? Are there any related legal agreements signed between the interested parties? Have the patients given their consent on the use of their data for AI? Are there assessments? Are those models, AI models, in accordance with the EU AI Act, Artificial Intelligence Act? Now there is a bell here that I have to say that as far as research is concerned, and we discussed this in the previous session, for research purposes, we do not need information consent from the patients. And also the EU AI Act restrictions, thank God, do not apply. Otherwise, we would never do any research on AI if we follow the EU AI Act regulations. So about supporting the transparency vis-a-vis the patient. So the question here is, the answer that we have to give is to the question, does the patient know? So first of all, the patient must know how her data is used. Point one. The second one is that patient also must know if the MD, the medical doctor, uses some AI tool in order to for the treatment of the patient, right? For the patient's diagnosis, for the patient's prescription drugs, etc., etc. So the ethical risk here that I believe it is in anyone's mind is that we do not want we people to become guinea pigs in tasks that we've never heard of and we don't know about and we have not given our consent for, right? So where is the human in the loop? The human should be informed prior to about the use of data, and also should any information consent should include opt-out options for AI model training. Now about validation, this is the fifth and last pillar of the five I mentioned before. Validation. Validation is AKA test, 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 and test. Whatever we did with COVID, we also have to do with AI models, okay? So what does it mean? It means that you develop an AI model and then you have to take it and validate it in different contexts, to take it out of where it was developed, validate it in different contexts, different institutions, devices, and populations. There is also another type of validation, which is temporal validation, that is, take the model and validate in different contexts and with data that come from different time periods. And the last one is robustness testing, which is introduce some noise in the model, noise that is realistic noise, right? And see whether the model continues to perform well or not. If there is a degradation in the performance, in the model performance. About ethics. So as I said, ethics transcends all vertical pillars, from problem selection. So which problem are we trying to solve, right? Is it clinically relevant, or are we just inventing a problem to invent a problem and solve a problem, and that's it, and write a paper, right? And I'm talking as a technologist, not as a doctor. Okay? So the second one is data collection and preparation, that has to do with informed consent, has to do with exploitation of vulnerable populations in my training data. The third one is problem solving. Is my AI model explainable? Is it biased or not? Moving on, validation. Is it ethical to use a model in a clinical setting when my model is trained only with one demographic? This is the example I gave before with the Manhattan wasps versus the population from the African Americans from Chicago. About clinical integration, this is very important, and I know very few about it, but one question is, does AI improves the clinician's autonomy or degrades it? So for instance, if as a clinician I use AI, am I getting better or am I getting worse in my job? Okay. So this is one question. And the other question is, if there is a mistake, a medical mistake, whose fault is it? Is it the medical doctor? Is it the algorithm? Is it the developer of the algorithm? Is it the one who runs the algorithm? Is it the one who collects the data? So this is kind of, like a black hole for me. I know nothing about, but I think it's the lawyers should have a look at it, or not should have a look, know that more about it. Continuous monitoring is if we use an AI model in a context, okay, and we see that it affects its performance, is getting worse, it affects the well-being of the people, is there an ethical duty to withdraw the model or not? So the AI model life cycle from alpha to omega starts from the problem selection and ends to the continuous updating of the model, the continuous improvement and updating of the model. In any case, I hope that with this short talk, I gave you the impression that, yeah, the humans must be in the loop, continuously in the loop, okay? Continuously in the loop. So if I start from the problem selection, the problem selection should involve domain experts. So I don't want a company, personally, I don't want a company or a university to come and say, I developed a model for this problem, and this problem is, nobody cares about it. They just did it to get money and develop unuseful things and I don't know, and write a paper, for instance. For data governance and data collection and preparation, we definitely need regulatory, legal, and compliance experts, as well as ethical and responsible AI experts, right? Because how to establish the processing of data and processing in general of the data, we need to have the legal personnel with us, be it DPO or lawyers. Now, ethical and responsible AI agents also have a major role as far as data collection and model deployment development is concerned, because they need to check whether the model is in accordance with the EU AI Act. Then we have domain experts who should definitely participate in model testing and model validation. For instance, I attend research talks by colleagues who say, you know, we developed this great model, it has this great accuracy, and I said, have clinicians tested it? And they say, no. I said, okay, so what? So it's precise. So what? I mean, this is like useless. It doesn't make sense. Give it to medical personnel to test it and see if it fits their needs or not. And last but not least, the technical personnel, which is people like us, software engineers, data scientists, AI model experts, computer science, etc., who are there from the data collection and preparation, because they need to work on processes, on software that collects the data from the registries, and also up until the model updating. Based on my experience, because my team from the Institute of Computer Science and I were responsible for the development of the registries of the precision medicine of this network, the precision medicine network on cardiology and prevention of sudden death in the young. We developed those databases, those information systems. We have to be there with the domain experts from the beginning, because we need to reach a consensus at what are the requirements of the people, what they need, and in order to be able to understand and talk with them the same language. So this is it from my side. I hope I didn't tire you a lot. Thank you very much, and I'm looking at the questions.
Good afternoon. Thank you for inviting me here, and I've been enjoying your conference. I must feel that I feel odd at times, because I'm probably the only geneticist, clinical geneticist in the herd of cardiologists. But I'm learning a lot from that. And what I wanted to say in the next few minutes, and I promise there are going to be a few minutes, is another way of looking at therapies and development of drugs. And the reason that I'm saying that is because, first of all, the definition of rare is academic and practically not much use. But to me, I am a clinician who applies the tools of precision diagnostics and would like also to reach to a goal of precision therapeutics. And that's how I approach it to begin with. And yes, there are a lot of rare diseases. I would like to correct my colleague Giuseppe. There are about 10,000, not 7. But it's irrelevant, it's immaterial. And the bottom line is that the majority of them, the overwhelming majority of them, the prevalence is quite low. And of course, population specific. So if we follow the other part is that only about 5% of that number of genetic diseases, they have treatments, they have credible interventions. And so I heard with interest, the last couple of days about all these myosin inhibitors and other medication that has been developed. And incidentally, these drugs have had significant effects in improving the clinical condition, but they were developed by Big Pharma. And because there is a certain cutoff as to how big is the market. And the pediatric disease market is historically and traditionally underrepresented. There are a number of reasons. One of the key reasons is that about over 70% of randomized trials for children are not subscribed. And therefore, they fail because they do not meet their goals. And that has an enormous effect on how a drug comes through the different processes, regulatory processes, and ends up in the market. So what I would like to point here in this slide is that it is only a very small sliver of genetic disease that can be approached by the traditional model of pharma development, okay? One reason, as I said, is the undersubscription of clinical trials. The second reason is that it is very difficult to do randomized studies. We're talking about instances where we have very few patients, not only in a country, but in continents. So these are two good reasons why the big pharma stays away from drug development for children. And so the second part of this, the right part of this graph, you can see that the long tail of rare disease is not commercially viable. And does it mean that we should not develop drugs for rare disease? No, to the contrary. So, since it's an audience of cardiologists, I decided to use an example from the cardiovascular system. And of course, I substituted cardiac surgery with genetic surgery. And of course, the favorite example is gene editing. But the point here that I would like to introduce is the fact that if we are going to develop treatments for rare genetic diseases, we need actually to validate platforms. And gene editing is one such platform. ASOs, oligonucleotide, is another platform. AAV is a third platform. So in order to do that, we need to think and create and validate platforms. Again, using my, not experience, but having been involved in the management of a pediatrician, that's how I started. So I deal with genetic disease. Incidentally, 80% of genetic disorders manifest in childhood. So 20% manifests in adulthood. And one, of course, of the major groups of disorders, genetic disorders, is what you are covering in your conference here, cardiomyopathies. And so when we have a child with a leaky valve or a hole in the heart and all that, there is a standardized way. Okay, first of all, you do a diagnosis. Number two is the doctor determines what needs to be done for this baby. Then we have standard tools and procedures. and at least in the United States, we have the United Network of Organ Sharing. Okay, you put your request there, and there is a standardized process, and then we go back to the doctor who does the surgery. Okay. So that's the process that has been standardized, validated, and it works. Okay. Now, genetic surgery, if we use that analogy. Again, we are dealing, by the way, cardiac surgery in some of those disorders are extremely rare. Okay, extremely rare disorders. And so the analogy in terms of prevalence is comparable. So let's say we have a child, a baby, with genetic disease, and we determine what is the mutation, and therefore, let's say that for the sake of this argument, this is a mutation that is amenable to gene editing. Okay? If we have a platform and a standardized way of using that platform, then we can create a custom CRISPR, let's say CRISPR approach for this specific mutation. This is the epitome of precision medicine. We fix it. And then, of course, there is a standard process and the doctor who takes care of that. Now, this is not, you could say it's theoretical. The pharma model has worked over the years, has worked effectively, but pharma is based on development of blockbuster drugs. That's the reality of it. Genetic disease, by virtue of its multiple, many different genetic diseases, and also its relatively low prevalence in the population, is not going to create a blockbuster product in pediatric genetic disease. So, if we create a system, an organism, a system, an approach, an organization actually, where we have a joint development, validation, and processing of those platforms, which can be under the control of academic centers, of course, patient advocacy groups will have a voice in that, maybe industry will have a voice in that, and of course the regulatory authorities will have a voice in that, and we validate a CRISPR platform. So we can take it, let's say, to the FDA and have a platform validation, which then it will be on individual actors, primarily through academic institutions, which end up seeing those babies, to implement those, the platform for that particular disease. Okay. There are a couple of examples, and of course everybody has read the last year or so an example of SD50, where a parent took charge of how they were going to deal with their child. Spastic paraplegia, by the way, one form of spastic paraplegia. And they created an entire network from developing the target molecule to actually producing it, okay? And then validating it, getting permission from the regulatory agencies, and then giving it to their child and other children. So what I'm presenting to you is another way to challenge your thinking as to how we could seek treatment for rare genetic disease. So it could be precision treatment, at the same time, it could be treatment that is the N of one, without necessarily bankrupting the family, which will not have the resources to buy that, will not necessarily subject the healthcare system to costs, high cost, and could be practical. So that's what I want to tell you, and I'll be happy if you have any questions to answer. Thank you.
Mrs. Cardiology, come to the podium, please. Ms. Cardiology is a representative of the families that suffer sudden death, and he's here with us tonight to make a short speech and statement. Can you go a bit close to the...
Yes. Okay. Good evening. First of all, I would like to thank the organizing committee for including me in this critically important conference on genetics and precision medicine in cardiology. I would especially like to thank Dr. Anastasakis for the excellent collaboration over the last 15 months, as well as for the profound professionalism and empathy he demonstrated under the difficult and unique demands of this program. I would also like to apologize for reading my presentation today. Under different circumstances, I would have delivered a speech without notes. However, one of the countless consequences of grief on the brain is cognitive decline, so my memory is not my ally anymore, and what needs to be heard today here cannot afford to be left out. My name is Hara Datsi, and I am a clinical psychologist, but today I am here mainly as a bereaved parent. The mother who said goodnight to her 17-year-old son one night and found him dead in his bed the next day. A young man who was full of respect and love for himself, for life and for people. Full of dreams about the summer and the life he had in front of him, waiting impatiently to live. On July 5th, 2024, I was forced to face the unthinkable reality that my son, who was perfectly healthy, both clinically and psychologically, died in his sleep. Yet, this unthinkable reality was the first of a series of other unthinkable realities and systemic failures which have brought me before you today. First and foremost is the reality of sudden youth death syndrome. My son, Kostis, was an athlete, so it was necessary for him to have the mandatory cardiac screening about 3 times per year since he was 7 years old. In the course of a decade, he underwent about 25 electrocardiograms, echocardiograms, blood tests. If we were certain of anything, that was the impeccable condition of his heart. No cardiologist ever mentioned sudden youth death syndrome as even a remote possibility. No one ever took a detailed family history, and no one ever alerted me so that I could investigate and educate myself. I do not know if it would have changed the outcome. What I do know, however, is that knowledge is power, and ignorance costs lives. Next, I face the reality of the healthcare system from the perspective of a parent left without answers. I received the forensic report exactly 6 months after my son's death. It did not provide any answer. A perfect body, a perfect heart, no trace of any substance use. The following day, the forensic pathologist called me on my mobile phone. I could hear the anxiety in his voice when he asked,
"Do you have another child?" When I replied no, I felt his palpable relief. He was terrified of finding another sibling dead in their bed. He was the first person in Greece to mention the precision medicine program in cardiology run by the Onassis Hospital, which performs genetic screening. But that's all he knew. Navigating the system in Greece to find information felt like wandering in the dark. The program's website, iCardiacNet.gr, wasn't updated since 2021, so it wouldn't come up in any Google search. I believe it still doesn't. In sharp contrast, just 2 months after Kostis' death, I had easily connected with the SUDC Foundation, Sudden Unexplained Death in Childhood, in the United States. They provided me with everything: scientific guidelines on genetic protocols, research, free specialized psychological support, bereavement groups with parents sharing the exact same loss, and the ability to take Kostis' blood sample from the Greek morgue and make the genetic testing in New York. I'm mentioning that only to tell you that SUDC from across the globe gave me a safe space to exist and the possibility of solving the mystery of his death, which is extremely important to survive and function, because no one should walk this path alone. When I finally managed to connect with the Onassis Hospital, I was told that I had to personally transfer my son's blood sample from the morgue to the hospital. There is no coordination between the mortuary and the Onassis Hospital, or any other hospital for that matter, resulting in the burden falling entirely on the parent. In torrential rain that day, inside a labyrinthine building with the brain barely functioning from grief, I faced an irritated employee smoking behind the desk, tossed a blank piece of paper at me. "Write down that you received the blood," she said. I asked for a pen. She sighed with annoyance. And there, a mother whose son had just died 7 months ago had to compose herself a certificate of receipt. At the same time, I had to watch a young intern walking up and down the stairs, holding a vial. It was my child's blood. Finally, she gave me an envelope in which she had placed Kostis' blood. I drove to the Onassis Hospital with the yellow envelope on the passenger seat, terrified that the temperature or humidity would spoil the sample. The geneticist met me at the entrance of the hospital, opened the envelope right in front of bystanders, and left without giving me a single receipt of delivery. Since then, the procedures at the Onassis Hospital have been carried out for free with exceptional scientific integrity and care. Dr. Anastasakis always takes the time to explain everything to a parent. The program operates for free, as I say, with high quality standards, but it lacks the speed and, above all, the funding to meet the growing needs. It is an exceptional program that clinically and genetically screens 3,000 people and runs with a part-time secretary. There are parents in this room whose child has died and are waiting 10 months for a reply from the colleague. I would dare to say that it runs only due to Dr. Anastasakis' commitment and immense sense of duty. The statistics of sudden youth death syndrome are overwhelming. According to the most recent survey by the Hellenic Society of Cardiology, which took place in 2019, I guess, about 300 people per year under the age of 40 are affected. These are deaths not from congenital heart diseases, but only from sudden youth death syndrome. And experts agree that the actual number is higher due to underdiagnosis. Another reality I was faced with is that parents are left completely alone against the system. There is no official service to guide us through the next steps. Speaking with dozens of affected families, almost none of them received the information I accidentally got from that one forensic pathologist. For this reason, we created the website www.natha.gr so that every parent can find the necessary process mapped out step by step in simple terms. Because a grieving parent cannot be expected to act as a detective. But we are just citizens, and we should not substitute for the state. It is of paramount importance, the state, to establish an institution or a structure that will guide the bereaved parents through this process and ensure a reliable connection between the mortuaries and the hospitals that are involved in the precision medicine program. In this way, the genetic research is promoted and families can take timely action to protect the rest of their members. Today, I do not just represent the families who have already suffered the loss. I represent the next 300 families who, by June 6, 2027, will be in my exact position. No one is immune to this. Minister Georgiadis, I know he left, but I will address him anyway. Do you think it won't happen to your children? Deputy Minister Agapidaki, do you think your family is safe? Dear attendees and participants of this conference, do you think you are immune? I know you think you are. In psychology, there is this term, optimism bias. We all believe nothing bad will happen to us. I know it, not because I'm a psychologist, but because that's what I believed too 23 months ago. 23 months ago, I was where you are. I was a proud mother of a healthy, happy teenager, a successful professional, and my family was a role model of calm and security. All this was lost overnight. The same thing has happened to many families before and after me. Without genetic screening, no family is safe. Your children, your nephews, your favorite godchildren, the children of your dearest friends may be carrying a ticking time bomb, and no one knows when it might explode. And believe me, you don't want to find yourself in my place. And this brings me to the most urgent request today, which is primarily directed to the Ministry of Health. Genetic screening for hereditary heart diseases must be integrated into and covered by AOP, the National Organization for Healthcare Service Provision for the general population. At this point, I would like to mention two major studies conducted in recent years. The first is the research by Dr. Julie Sherrill, University of Kentucky, who through population-based studies established that after a sudden death, up to 135 people, relatives, friends, colleagues, community, can be negatively affected in various ways. The second is a Swedish study of 2018 that utilized data from the National Archives of the Nordic countries. It found that mothers who lose a child, especially when the death is sudden, face a 31% higher mortality risk in the first 4 years after the loss of their child, whether from cardiovascular disease, cancer, or suicide. And that risk remains significantly elevated for several years afterwards. The conclusion is clear. We are no longer just talking about deaths from sudden death syndrome. We are talking about an entire micro-society put at risk beyond the genetically affected immediate family. I have experienced this firsthand when one of my son's friends committed suicide 2 months after Kosti's death. For all these reasons, the coverage of genetic screening by AOP is a duty of the state towards life itself. Modern science now provides us with the tools to prevent tragedy before it strikes a family and the community. Genetic identification offers a definitive diagnosis and allows targeted testing of relatives, identifying those who are at immediate risk before it's too late. By approving this coverage, you are not burdening the budget, you are investing in prevention. You are eradicating sudden youth death syndrome from the society of tomorrow. Informing the public and ensuring every citizen has access to genetic testing for hereditary heart diseases is one of the most profound acts of responsibility by the state and the Ministry of Health towards society. After all, it is a law and you have the power to change it. Thank you for your attention and for being here today. Allow me to dedicate this speech to the memory of my son, Kostis, and to Nicoleta, Stelio, Kostadino, Dimitra, Vaso, Tony, Apostoli, Giorgo, Vasili, Iona, Navsika, Costa, Panayoti, Marina, Ioanna, Mary, and all the children who froze in time.
Trace us the gaps of our system at the moment and the need that we have to improve our services and the role that we all believe that the genetic test has in the current clinical practice. So I would like a comment from the panel.
Thank you. Just when I was about to tell you all how proud I am to be part of this network and how grateful we should all be to the people who conceived the original idea and brought it 10 years after to what it is today. Mrs. Dazzi with her, with what she said, I think landed us in harsh reality. But being realistic and optimistic at the same time, I think that, and it's a unique session on the ecosystem, because the ecosystem of inherited diseases is, well, at the center, most of the times has someone who has died. And his or her family. And I think it was a great idea that you orchestrated that, bringing also the families in this discussion. And I think it shows that to offer good healthcare services, you don't need only good medics. You need many players to support the ecosystem who need to work together. And I think it shows that this process, this adventure, needs a lot of funding. Plus a change of culture, obviously, but it needs funding. And I think that the fact that this initiative has been funded by the Greek government, the governments, the Greek state, I think something that we should admire as Greeks. And I have great respect to the initiative because it's a unique example. You don't find that very often. And it may be funded by the VHF or charity organizations, maybe also by the UK government or other European states, but it's a big thing that it started in Greece. We have to improve it. We have to continue it, and it's a pity that the Minister Georgiadis is not with us, and I think we should give him some sort of summary of what has been said today. But it's something that we should continue, and we should improve it. Publish the data, show how much the work has been done, well, and how much work still needs to be done, and how many things we need to improve.
We were very profoundly touched by what you said, and I have to confess that running a department of cardiogenetics that we have developed from scratch, we do not have this the same, let's say, approach in the beginning, but we have developed, we have advanced through the interaction not only with other specialties, not only with other health care allied professionals, but also through the interaction with patients. And I think this is the critical moment when you realize that it's not what you do for you, but you do it for the other person, and you develop and you advance with them. And then when you listen to the patient, when you work closely together with them, then you identify your exact role, and then you realize what your mission is. I think it's of the utmost importance to work together with the alliances of patients, and together, when we work together, then we don't realize how powerful we are, how powerful we become when we work together. And the data we have been extensively discussing about data and collection of data these 2 or 3 days, but I think this is one part. The other part is how are we going to be persuasive in the healthcare system, in the payers, and in the government. And then, when we work together, then we are the most powerful team that we can ever be.
Professor Elliott, you have gaps in your system in England. I mean, and what do you do when it's not easy to come up with a result through the genetic analysis? Because we have such cases as well. We have cases where we have sudden deaths, but even the genetic analysis is not capable to give us an answer.
Yeah, I think along with the rest of the panel, I'd like to thank you for what you've just said. Thank you. We always need grounding in the reality. So I've been trying to make a difference in this area for 20 years. So I was involved in what we call the National Service Frameworks in the sort of mid-2000s, which was an attempt to change the whole of the way in which we deliver cardiovascular medicine. But the last service framework was around this issue of trying to resolve the pathway from the death of an individual through to referral into a system for subsequent diagnosis. The big gap for us, and it still remains, is the gap between a coronial system, a legal system, and a healthcare system. Forgive me, I don't know how it works here in Greece, but in the UK, we have a coronial system which is purely legal. It's most of the coroners, and there are about 180 of them in England, are non-medical, so they're mostly lawyers. They do the job part-time. Their responsibility is to ensure that there is no foul play. This person did not die from misadventure, from murder, from poisoning, or whatever. Their job is not to make a medical diagnosis. To give you some idea it's 180 coroners, and they deal with 100,000 deaths a year. So even the process of getting a post-mortem to say that there is an identifiable cause is a challenge. There is no system of coroners, pathologists. As a qualified medical practitioner in the UK, theoretically, I can do a post-mortem. And of course, most pathologists don't want to do post-mortem practice. The problem is the handover between the coroner. So the coroner says, okay, this person wasn't murdered. How do we then get that family, that individual, into the healthcare system? Now, we started to develop pathways for doing that. We had pathway coordinators, there was buy-in from the government, and then unfortunately the political tide turned, and we got that close, I think, to having sort of designated pathways, and it didn't. Fast forward 20 years, we now have the British Heart Foundation Initiative, which is trying to do the same thing, and the BHF have funded nurses, coordinators, bringing together the coroners, and it's been working actually really quite well, but of course it's funded by the Heart Foundation, it's not funded by the healthcare system, and when the BHF funding ceases, we'll be back to where we were before. So the gap still exists. The one thing that has changed for the better is genotyping, and your call to have genotyping as part of the healthcare system is, I mean, we've talked about it a lot over the past 2 days. It's nonsensical that it isn't. I mean, why is a genetic test any different from doing a cardiac catheter or getting a pacemaker? It shouldn't be. Or having a full blood count, or having a tumour marker measured. It's about making a diagnosis. And so we've got to make the genetic test non-special. It's just something that you do in this particular scenario, and that should be picked up by the state. And I think that's something that the network can lobby for. You clearly have political backing. And that, if you're going to campaign for anything, it would be to have a national genetic testing service within your healthcare system. The bit about the coronial bit, what you do with some of that, I can't really comment on because I don't know the system here. Final point, if I may, is just that, I gave a little bit of a speech earlier about how doctors approach patients, but I think there's a problem about systems. And I'm sure there are many people in this room that have been unwell and have had to encounter a healthcare system. And being unwell is horrible because you're treated like a lump of meat. And you're treated like a lump of meat when you've just lost your son. But it's endemic. It's a problem we have in managing health, mental, physical, bereavement. It's a societal problem, and it's not unique to Greece. It happens everywhere.
Well, Mrs. Daci also mentioned the gaps that we have in our system. Mentioned that, for example, our website is not functional, of the network, I mean. That it's not easy to find us. The system, the coronary system in Greece is very problematic. We all know about this. And also that we don't have a timetable to run in a fast track or in a lower way, not so fast, the results. Because in some cases we need to run very fast. In the cases of sudden death and in the cases where we're trying to re-stratify our patients, and the only way to do this is through the genetic analysis. So the thing is that we're a few doctors that we know about these things, and it's very difficult to pass it to the whole cardiological community. And of course, because of the treatments now and because this area becomes more attractive because of the drugs, the new treatments that we have, this maybe will change things, and we hope will change things, and that's why we're here, and that's why we organize this conference, and we have this help from our colleagues from abroad. And so I would like just to come back with the previous lectures and make a combination. Maria, what about, I mean, someone dies and we perform genetic analysis and we found things. And how can we protect these things? I mean, for example, in our hospitals, many of the information is exposed. Not in Onassis, but in other hospitals or the public sector. I don't think there is any distinction between the clinical information and there is a very important difference that the other clinical informations are time dependent, but the genetic information is there, is characterize a family, a person, relatives. And so that's why it's different. That's why it's so important, because it's something that stays there.
It's not an easy question. There is no answer to that. On the one hand stands the right to privacy and autonomy. On the other hand stands the legitimate interest of all family members. Based on the work we have done in the network, I would venture to suggest that this is an area that Europe needs greater legal clarity and a new legal framework, I would say.
The solution to us is I mean, if there is a good relationship in the family, we can manage to do it. Otherwise, it becomes very difficult. What's your experience?
That can be an issue as well as which of the next of kin is actually responsible in some families. That can be problematic. Is it a blood relative? Is it a spouse? So But it's assisted by having a person whose job it is to help a family coordinate. So we actually, as part of the British Heart Foundation project, we have coordinators who work with the families, who work with the coroners and what we call coroners officers, who actually sort of navigate what can be an extremely difficult and emotive time following the death of a person. Most of them in the project are nurse specialists, so they're nurses often with electrophysiology background or expertise in inherited disease.
But it has to do with with consent?
Yeah, absolutely. Yeah. So they manage the consent process, the transferring of samples, tracking down samples. If relatives want to be referred, coordinating with their general practitioners to get them referred, but you need someone to coordinate that in that period of time, which is devastating for the whole family.
Yeah,
And then Professor Bolletz.
Yeah, I can say tell you what happens in the US. So the coroners are pathologists, and actually in Houston, so once they've excluded that the death is not a homicide or drug related or anything, and it's we actually go there once a month and help them come to a medical. We help them with the hearts and the lungs. So that's where I get involved. So they collect the cases, and I think so. They are allowed to do the genetic testing. Now, how they release it to the relatives, I'm not sure what happens at that end. But for us, when I get involved in an autopsy at the medical center, I recently had one of the doctors whose 45-year-old husband suddenly died on the treadmill. I involved in the autopsy, even though I don't like autopsies, but I do get involved when I'm called upon. It was a big heart. The permission was taken from the wife because they have 2 little kids. She actually agreed that we have to get the genetic testing done, and when the genetic testing results were received, they were delivered to her, and then she went to the geneticist for her children. So that's sort of the protocol. We have to take permission from the next of kin before we send it out for genetic testing, and the clinicians do it before they ask us for the autopsy, so we know what we are dealing with before we get into the autopsy suite. For biobanking, you mean, for autopsies? So autopsies, in general, is not considered, once a patient has died, it's not considered a human thing. So we can collect the tissue, but if I want to do anything with that, genetic testing is a different story. But for anything else, I would still have to get an expedited IRB, But it's essentially autopsy tissues are not considered human subjects in the US. GDPR does not apply to disease. But we do still have to have a letter from the IRB taking that permission. Yeah. I just wanted to say what happens.
Thank you very much. Professor Bolletz. Yes.
Otherwise, I understand that the children at the age of 5 years, let's say, must go or undergo all at the genetic testing, which is impossible for different reasons. Am I right?
We have also other ways to pray. I mean, for example, we know that for the sudden death in the young is related with the inherited cardiovascular diseases. So if we here in Greece now we have a registry of inherited cardiovascular diseases, when actually is a way to identify people that they have a potential to die suddenly. So this is a very important thing, because we can trace these people before death finds them. So this is one very significant thing. Of course, the other thing is that we find them if we have already an event in the family.
So you don't just need someone to die, but you have all these clinics of the network where people come and are diagnosed with a cardiomyopathy or an inherited cardiovascular disease. They are not allowed to have a genetic test for free unless they do it via the network. And then after their diagnosis, then there is a cascade screening of their families. Again, these tests are not given for free by the Greek insurance, by the Greek government, or by the Greek state. And this is, I think, what the network is campaigning for, is to offer to the diagnosed people with cardiomyopathy, with some criteria that can, it can be discussed and arranged, and to their families to have this, the appropriate genetic test done for free and to be reimbursed by the Greek state.
Which means that we save lives through the family screening.
Makes sense to me.
It's not a population screening.
So that means to me that there is an urgent need for the people of the country under certain criteria, as we do with the prevention program, to come to this clinic. Second thing is we need certain strict subway criteria to have the genetic testing for free. If there are no criteria and everybody can write for the genetic testing, nobody will do it.
We have done this as a Greek community. We have done this for what we call the expensive drugs, injectable drugs for cholesterol, for example, where we make a small report, which is then that fulfills the criteria for someone to get this expensive drug. We put the application in the system. Then we have a committee of people who look at it and decide that this is approved or not. My very simplistic approach would be to follow that sort of procedure.
Okay. So what you said,
for the genetic test.
What you said means that it's covered. One, that it's covered, but not that free that you want. It's covered
in a controlled way.
Under a control system. So it's not that we don't, it's not covered. And the last thing,
it's not covered. This is what we suggest. This is what we recommend or we propose. So well, we can find a way.
That so far is covered from the network.
No.
Okay, I don't think that if you put the criteria and you go and push things, it will not be covered. I think that it can be done. My view, my experience of other things which have been paid, but you need come with a map, with criteria, and also to get an idea, to give an idea over a year in advance.
Professor Pleris, can I just add? That was exactly my point in the very first day, because when we presented some data from the network, from all the genetic tests that have been done under the strict criteria of the network, 2/3 were either positive of the genetic testing, either positive, or the US of a non-significant, which is some kind of importance. Which means that you don't have to do an infinite number of genetic testing. If you apply strict criteria, then you limit very much the number of genetic tests that have to be done, and then the yield of those genetic tests is very high. So it's very cost effective. So the criteria is the message.
This is what I said. And the last thing, I always see it's not something which happens here. There's always a discussion for exceptions. So what's going to happen if the family says no, if the father does not own, if grandfather does not own? In my experience, if the patient trusts the doctor, almost 100% does what the doctor asks to do, explaining the benefit, and that's what the doctor asks to do. This is my experience, long time I practice medicine.
Yes, the difference is that here we don't have only the doctor, the patient, we have the family as well. The difference is that we don't have only the patients, we have the
Say
family.
you lost a child, or if you want to have another child, or your mother, your sister have a child, you have to test it. Who will say no? Nobody. Or almost nobody. I'm not saying, I don't, you have...
That's a good message.
Yes, yes, I'm not saying, well, crazy people found everywhere.
But then it's up to them.
Yes, but you have to make an inquiry and see how many people said no. For example, for donation in transplantation, we know that 25% say no, but we know that it's 25%. It's not 70%. Before we measure it, before we count, we thought that it was much more, but it's not. This is what I suggest.
No, this is a good message. So I think we have to stop here and. Yes, please.
Because you talked a little about the gaps, and it reminded me of an editorial I wrote in the Hellenic Journal of Cardiology, and the title was, you will recognize it, Mind the Gap. And it was about the genetic information and the literacy or the illiteracy of the population. And in order for because we're talking about people, and in order to give the power to the people, you have to educate them. You know, Abraham Lincoln said that you have to govern the people by the people, for the people. And in order to give a legitimate, let's say, aspect to this, the people have to consent when you govern them. And they consent only if they are educated. And then this brings us to the literacy. And then the literacy is obviously for the medical personnel, but also for the patients and the relatives. And it might be easy to educate and literate the medical personnel, but for the people it's not so easy. And you might think that the older generations need more, let's say, effort to be literate, but also the younger generations need to be trained because they have access to digital tools, they have access to the applications, but we have to teach them how to distill this knowledge in order for this knowledge to be helpful for them, because they are bombarded with tons of rubbish.
Education that Mrs. Dutton found peace when she saw the documents and she read about sudden death and how prevalent it is and what are the problems worldwide. You may need nurses, you may need not just doctors or only geneticists or coroners, you also need people who link one doctor with another doctor, or the doctor with the patient and the family.
You're totally right, Katerina, and I think the psychologists, they use a very important word, which is co-creation. You use it a lot, the psychologists. We have to co-create.
Mrs. Kudulaki talked about data. If patient, I don't know if this is the correct word, but if we families don't come from the mortuaries to the hospitals and to the programs that run regarding this exact issue, then you won't have data. From those names, only 3 are in the program. 3 other families don't have the resources, the knowledge, or the courage to make it to the program. So, 20 names, we only have data from 3.
Thank you very much. I think, yes, so the last thought, because we have...
So, I wanted to say, to make a point exactly to what you said. So, in the network, we have two registries. One where we keep the clinical and genetic data of patients, and the second one is a registry for people who died suddenly. Right? So, it's the first digital registry. If you go to a mortuary, people, pathologists, forensic scientists write on pieces of paper. So we said, why don't, so for the moment, this registry for death, for the deceased, is actually fed with data by two forensic, which is both from universities, because this is a research project. When we try to go and say to the, to the other, sorry, the other, they belong to the Ministry of Justice. So this is a different, there is different legislation there. But the point is the following is, if we were able to connect the two registries, so for instance, if somebody goes in the registry of the deceased, and we have information about this person or about the family of this person in the registry, of the clinical registry, then we can get data from the one and fit the other. So this will, sorry? Exactly. So this will make the process faster. But in order to do this, the state, because the state comes here, must establish a framework in which this works. So there must be an initiative from the state, which I think is extremely difficult or nearly impossible to have, because there is no vision about it. You see, so there is no vision about it because they don't understand the problem, and there is no vision about it.
We have to stop. All right. Thank you very much, and I would like to call Professor Vardas and Professor Elliott.